one of the members of the NMC bill.
We are live, sir.
Hello, everybody. Greetings from Indian Medical Association. I am Dr. K.K. Agarwal, President, Confederation of Medical Association of Asia and Oceania. You are watching, this is 33rd academic session from Indian Medical Association on COVID-19. I have with me Dr. J.M. Kaul, an excellent teacher, mentor for many, specifically people who can't reach any professor to understand. Former director professor of anatomy at Maulana Azad Medical College, academic coordinator, and also the later on academic coordinator and consultant at Dr. B.S.A. Medical College, B.S. Ambedkar Medical College. She had served in the MCI as UG committee head, and she is also a former member of the original National Medical Commission bill. So I'll request Dr. Ramesh Kumar Datta to give introductory remarks.
On behalf of Indian Medical Association, its president and honorary secretary general, I welcome Dr. Kaul, as well our resource person, Dr. K.K. Agarwal, who is my guru also. I learn so many things every week from him. He is the chairman of CMAAO as well as the past president of Indian Medical Association. With these remarks, I welcome both Dr. Kaul as well as Dr. K.K. Agarwal to start with today's proceedings. Thank you very much.
So when this virus enters our body, there is a viral response and there is a host response. And today everybody wants to understand the host response. When this virus came, the first news came that this virus is reducing CD4 cell count, and everybody started thinking, oh my God, are we getting something, a new HIV virus? And then we came to know that there is a CD4 cell, CD8 cells, there are CD regulator cells. We never understood the physiology part of the cellular physiology. We started looking for Th1 response, Th2 response, Th17 response. Then people started talking, India has a specific Th2 response, therefore the mortality is low. And everybody of us were getting confused, what are we talking about? Because we had all forgotten the word thymus as we developed our clinical practice. So at that moment, I invited Dr. Kaul in one of our roundtable. And then when she started speaking, 25% of that went over our head because that was something new to us. And since then, we are, at least I am reading. So I invited Dr. Ved Prakash Mishra once to talk about the physiology of thymus. And so by that time, we knew a little bit. So we thought of relearning thymus anatomy. And because unless you understand the anatomy of thymus, the generation of the T helper cells, suppressor cells, CD4 cells, and then everybody started talking about T and B cells. So we thought we need to relearn. First, T means thymus and B means bone marrow. So today, to IMA, all my colleagues, I'm presenting to you Professor Kaul, an expert in this particular thing. We'll understand all about thymus, why thymus is important, and why thymus is extremely important as well as COVID is concerned. Madam Kaul.
Thank you, sir. Thank you so much for your kind words. Let me share the screen. Is it visible?
Yes.
Okay. Good afternoon, everybody. I think today we have really come down. I have really tried to simplify this lecture so that all my clinical friends get a sense of what we are talking. The discussion is on the role of thymus in enhancing immunity. It could be anything. Again, today we are specifically talking about COVID-19, but we are going to emphasize the role of thymus in immunity and what thymus is. If we look at thymus, if we were to look at thymus, what is it? It's a primary lymphoid organ besides bone marrow. We have two primary lymphoid organs, thymus as well as bone marrow. And thymus provides T lymphocytes to the whole body and provides a microenvironment in which T cell precursors undergo development, differentiation, and clonal expansion. As Sir has just said, that there are different clones of T cells. So these clones are formed and expanded. They are differentiated, how they develop. All this is happening in the microenvironment of thymus. Of the T cells. It therefore provides specificity of T cell responses, different T cells giving different kind of responses, and also it also gives us immune tolerance to self, which is extremely important for our survival. How is it achieved? It's achieved by interaction between thymocytes, the scaffolding that the thymus has, which are the epithelial cells, the antigen presenting cells, and the chemical factors of thymic environment. It's amazing to think that this little thymus, which we had all relegated to the background till now, and we always would say, well, it's a degenerating organ, has so much role to play. And there is so much interaction between thymocytes, the epithelial cells that are closely surrounding the cells here, the antigen presenting cells, and the chemical factors which are in the milieu of the thymus. Amazingly, it's part of the neuroendocrine axis of the body, and it influences and is influenced by the products of this axis. It varies at different stages of life under the influence of different physiological and pathological states. If we look at anatomy, we all know where thymus is. Greater part of thymus lies in the superior and anterior, as well as inferior mediastinum, right in the front of the neck and the thorax. The lower border of the thymus reaches the level of the fourth costal cartilage. That means it's just above the anterior mediastinum. Superiorly, extensions into neck are common, reflecting the bilateral embryonic origins of thymus. Shape is molded to the adjacent structures. It's soft, yellowish. I have worked a lot on thymus from fetal ages, month 6 to old age. It molds to anything that is present over here. It gets space, it looks bigger, it has, as you grow older, it gives a whitish, fattish color, and it's no longer red looking. Reddish in color to begin with, and weighs about 20 grams in adults, covered by a distinct capsule with increasing age, which becomes yellowish in color, and the older thymuses can be distinguished from the surrounding mediastinal fat only by presence of this capsule. It just looks like a little lump of fat to begin with. Now, what are we interested in? We are interested to look at the thymic microstructure. If we look at this thymic microstructure over here, I would like to bring your attention here. This is the periphery of the thymus, and outside it has a fine capsule, and this capsule sends septa within the substance of the thymus. And therefore, you can see here, there is an extent of this septa, and it divides the substance of the gland into a denser outer portion, which is the cortex, and a looser inner portion, which is the medulla. If we look at the cells in the outer portion in the cortex, they are smaller cells, granular, and they are predominantly the lymphocytes. But each part of the thymus has an interwoven epithelial cell scaffolding in which these thymocytes lie. Medulla has a lot more epithelial cells, but it has more. In fact, you can see the lymphocytes are more scattered, and the epithelial cells are bigger, scattered, and very prominent. The capsule sends septa into cortex, extending only up to corticomedullary junction. Thereafter, the medulla is a continuous structure in between and goes into various sublobules of the cortex. Continuing with the microstructure, in the cortex, as we said, there's a thin subcapsular cortex. Beneath that is the main cortex. The lobulation forms the main pathway for the blood vessels to travel. And below the cortex, there is a small space. It's a filtration space from where the afferent lymph nodes, there's a small space. Medulla is continuous and from one lobe to another, and a loose layer of epithelioid cells permeate both the cortex and the medulla. If we look at the epithelial framework, it's a sportive collagenous reticular tissue which has epitheliocytes. Epitheliocytes vary in size. If we look at where are these epitheliocytes, I'll show you in the next slide, vary in size and are connected to each other by desmosomes. They form a network which is going throughout the substance of the thymus. There are 6 subtypes of epitheliocytes. The first one is subcapsular in position. They form continuous monolayer around the perimeter and a sheath around the cortical capillaries, total sheath around the capsule, and then along the blood vessels, they go in the perivascular space. They have major histocompatible positive surfaces and a capsule facing negative surface. And these are the epithelial cells. They attract the stem cells to thymus. Now let's see this is the layer that I was artist description of the layer. This is the monolayer that we talked of just now. And this also goes along the blood vessels. You can see there is a blood vessel over here, and this you can see an extension of the epithelial cell around the blood vessel. Type 2 cells are large active cells which are present from the cortex as we come towards medulla. From there, 2, 3, and 4 are they are the more differentiated epithelial cells, along which the thymocytes are getting more and more differentiating and maturing. A subset of type 2 and 3 cells are large epitheliocytes. You can see over here one such epitheliocyte which is large and is roughly surrounded by many thymocytes. There's a count of 50 lymphocytes also around one epitheliocyte, and these are the thymic nerve cells. We can understand what these cells would be doing. They would be giving all kinds of support system to the thymocytes. Some of them secrete the interleukins. Some of them have multiple functions, which we'll do later. Type 5 and 6 are medullary in position. That means they are here. These large cells, these green cells are the large epithelial sites. They are present in the medullary region. And you can also see the type 6 one, which forms the Hassal's corpuscle, which are epithelioid bodies, which start from fetal age only. The first evidence of Hassal's corpuscles have been seen as early as 5th month of intrauterine life, and they go throughout life. If we look at the thymocytes, the T cells that are present in the thymus, then what are they? These cells carry out cell-mediated responses, not directly dependent on antibody activity. They are included in cellular immunity. T lymphocytes may have effector action when the antigen of donor and the recipient are not similar. They may have action directly or indirectly, and they act against viruses, tissue cells, neoplastic cells, allografts, what have you. They act by 2 formats. Type 1 kills by cytotoxins. Type 2 is a combination of defense actions through release of cytokines, which further act on the other kinds of cells. If we look at how the lymphocytes are placed in the lymphocyte, let's see. We just talked of blast cells. We just talked of blast cells in the subcapsular region. They don't if we, let's orient ourselves to this picture. This is the, sorry, what's happening to it? This is the cortex of the cortex. This is the thymus, medulla. Now let's see how are these T lymphocytes placed. We have subcapsular cortical blast cells. They don't express any charge. They have no complex on them. They have nothing. They don't express any marker. These cells undergo mitosis. They develop T cell receptor complexes and become single positive, and they express CD3 markers. So we have the first cell developing, which is a single negative cell and has CD3 marker. I again want to emphasize it. Blast cells, the first one, it does not express any marker. So they are called double negatives. They have no marker, positive, negative, nothing. As the maturation processes undergo, they undergo mitosis. They develop T cell receptor complexes. From here, we will call them as TCR complexes. And they become CD3 positive. So since it has only one marker set, so it is called single positive. With further expression of TCRs, they become double positive, both for CD4 as well as CD8. This is roughly at the corticomedullary junction. We can see here that the cells are both, these blue cells are both CD4 and CD8 positive. So these are now called double positive cells. As we go further towards the medulla, after apoptosis, this is the time when apoptosis happens in thymus. The cells that need to be in thymus, that is the cells that will recognize self, will be kept, others will be destroyed, because later only the cells that will recognize the cells will not be attracted. After it reaches medulla, apoptosis happens and acquires some of the cells acquire CD4 marker and some of the cells acquire CD8 marker, and they again form another kind of cell charge, which is known as single positive cell marker cells, predominantly either CD4 or CD8. Then medullary single positives may either be exported to periphery, where they will be fully competent, one type, one pathway. The second pathway will be, they will recirculating activated T cells have entered medulla secondarily. So these ones, which are either CD4 positive or CD8 positive, are the ones which are either exported to periphery or are recirculated within the medulla. One second. Now, how do they act? They have controlling actions. They either induce or suppress immune responses in other lymphocytes engaged in tissue responses, as well as variety of non-lymphocytic cells, such as derived from bone marrow. That means T lymphocyte by itself is not, it's not only having action only on itself, it also has a modifying action on B lymphocytes. Cytotoxic cells, which release toxic lysosomal proteins, which are porphyrins, they're able to lyse the cell membrane. Recognition is by sensing foreign antigens in combination with class 1 major histocompatible molecules that are expressed on the surface of all nucleated cells. That is why right in the beginning, they will not destroy the cells that have the self-bearing antigen. Other lymphocytes that are larger in size and contain cytotoxic substances that can kill but don't have T cell receptors are not restricted by MC restrictions. They are also part of the pool. If we look at the delayed hypersensitivity reactions, which are related to T cell react by synthesizing cytokines, which may act by chemotactic substances, stimulating phagocytosis, increasing the destructive activity of macrophages by releasing cytokines which act directly on B cells. Interleukin-2 acts upon B cell and T lymphocytes to stimulate and proliferate and mature. It's needed for stimulation, proliferation, and maturation. And the helper CD cells 4 phenotype, it's vital to proliferation and maturation of B lymphocytes. So what I'm trying to say that T cell does not act only in isolation. It acts along with B cell, carries B cell with it as a team, and both of them have action predominantly T cell through the through the chemotactic substances, and B cell in the format of the antibodies. The suppression activities. Now, what is that decides that this is where this is optimal, and beyond this, I am not going to go. Certain T cells, when stimulated, release cytokines that actively suppress the defensive action of B cells and other T cells. This balance between positive and negative control is very important in maintaining the fine balance of destroying the foreign antigens without the body itself being damaged. This positive and negative control probably goes haywire in the COVID infections or any infection which is so massive as COVID is. And that gives rise to all the problem, the cytokine storms, all kinds of storms in the body. Natural cells that are large, killer cells are large granular lymphocytes that secrete interleukin-2 after attaching themselves to the target cells. Now, what is CD? What does CD mean? What do we understand by CD? CD determinant. When monoclonal antibodies are raised against cell surface antigens of human lymphocytes, it was found that different classes of T lymphocytes were grouped according to the characteristic range of monoclonal antibodies they bind. As far back as 30 years, I used to work on thymus at AIMS, and we used to do electron microscopy, and we had seen this under scan microscope. Some T lymphocytes had very different surface and characteristics, and some were absolutely round and smooth. And as a young faculty, it was very difficult to understand what's happening, and so much literature was not there. And now it becomes very clear that T lymphocytes, depending upon the cluster it's carrying on it, will have a different structure. And these classes of T lymphocytes, there are different classes of T lymphocytes. So these, according to the markers, have been given numbers. And this is known as cluster determinant number, which we call in abbreviation CD. The CD4s, the CD8, the CD3, all kinds of CDs that we call. All true T cells express CD3 molecular complex, which is responsible for signal transmission via the T cell receptors. It's the interplay between the T cell receptors and the complexes that will express the kind of cytokines that we see. They also express either CD4 or CD8 complexes. And CD4 cells include also helper cells, which is important in triggering antibody production from B lymphocytes, cytotoxic cells, and other cells involved in delayed hypersensitivity reaction. CD8 cells comprise the cytotoxic cells and others with suppression function on other cell types. Natural killer cells are CD3 positive and do not express CD4 and CD8 markers. At present, CD4 population has been divided into Thymus 0, Thymus 1, Thymus 2, based on the mix of cytokines released by T cells following antigenic stimulation. This has got expanded into many now. And I thought, since it's a very basic lecture, let's stick to these only. Both CD4 and CD8 molecules can be regarded functioning as co-receptors to the receptor sites in recognition of antigens. I think we can skip this. Now, what are the non-lymphocytic thymic cells present in the thymus? There are mononuclear phagocytic cells in the form of monocytes and interdigitating cells. They present antigens to T cells as they move from cortex to medulla. There are fibroblasts and there are myeloid cells, probably to facilitate the movement of the thymocytes from cortex to medulla. If we look at the secretions of thymus, then what are the thymic hormones that? Principally, it's the thymulin, thymosin, thymopentin, thymic humoral factors. And we've been hearing so much about zinc. Everybody has been having zinc for past 8 months. So much so, many people have had excess zinc 4 times, and we have reports of zinc toxicity and vitamin toxicity and vitamin D toxicity. This thymulin relies on zinc for its biological activity. That's why zinc is important. And these factors, they exert immunomodulatory effects on the lymphocyte maturation, induce the markers of early differentiation on lymphoid cells, and enhance T cell function. Other soluble factors are cytokines action complexes. Interleukins 1, 2, 4, 6 are secreted by thymocytes, and interleukins 1, 3, 4, 6, and 7 are secreted by thymic epithelium. Cells bearing receptors for all these cytokines are present in thymus. It's important to note interleukins are not secreted only by thymocytes. The epithelial cells in the thymus are equally important in priming the thymocytes to function and also producing interleukins on their own. Neuroendocrine thymic interaction. Hormones can influence thymic function, and thymic factors often affect other endocrine organs. Although thymus is not grouped as an endocrine organ, but definitely it has receptors for sex steroids, triiodothyronine, and luteinizing hormone, release hormone. Receptors on thymocytes for corticosteroids, oxytocin, and estrogens have been found. And it has also been seen that high levels of corticosteroids kill the cortical thymocytes by causing apoptosis, and the low levels have a potentially thymopoietic effect. This also enhances the migration of prothrombocytes into cortex, which is important. Does thymus stand same throughout life? No, thymus has age changes. Age changes actually begin from prenatal life only. Thymic changes during postnatal life, largest relative to body weight at birth, increase in weight up to first year, after which the weight is fairly constant, around 20 grams until 6th decade when the reduction occurs. Reduction, although the weight remains constant, it's increasingly infiltrated by adipose tissue at the expense of active lymphoid tissue, which has come in for a lot of discussion at the moment. It is said, does it set in immunosenescence? Does it bring down the immunity of a person because possibly there are less T lymphocytes? Fatty infiltration usually complete by 4th decade, and only patches of medulla and associated cortex are spared. In fact, in an old thymus, it really becomes difficult to even make out the cortex and medulla. Number of thymocytes present are greatly reduced, but thymocyte production and differentiation persists throughout life. But number of T cells are less by any standards. Then what could be its role in severity of COVID-19? Observation of past few months have shown that older adults were at increased risk of grave illness compared to children. As we have said, could it be because of a compromised T cell status? Emerging research has shown that there is a marked decrease in the number of T T cells in some gravely in patients, as Dr. Agarwal was just now saying. Aging is a multifactorial process that could cause loss of function that leads to and is the primary risk factor for all major pathologies. Pathogens may be more infective and prevalent in elderly, yet may affect the young and not be they may affect the young also. Gerophilic in nature, will infect both. Both will suffer illness. Depending upon the immune response, give its response. But there are some infections, including COVID-19, which are gerolavic. That means they are substantially more severe in elderly. And here, I was just reading an article which has come in Science about aging, where they have said that could it be that because of the number of lymphocytes and the immunosenescence, the aged are more vulnerable to COVID-19 infection. Immunosenescence major factor being the chronic involution of thymus with increased age. Age-related senescence leads to reduced ability to resist infections, while infection produces biological damage and loss of homeostasis. The role of T and B lymphocytes has over the time opened up vistas of knowledge and thrown open many questions. It has promoted the understanding of memory, tolerance, autoimmunity, immunodeficiency, as well as inflammatory and immunopathological phenomena. Role of immune boosters, where a 70-year-old immune system will behave like a 40-year-old, needs to be explored. And I read an article where they have 2 or 3 drugs, which are not therapeutical at the moment, which have reversed a certain amount of aging in some individuals. Recent investigations have highlighted in early COVID patients role of increased pro-inflammatory cytokines, impaired type 1 interferon response, and functional exhaustion of antiviral lymphocytes. These are the references from where the material has been taken. Thank you, sir.
Sir, you are muted.
Thank you, Madam Kaul, for a beautiful basics of thymus. Just for my understanding, I would like to ask some more basic questions. Can we redefine APC, antigen presenting cell?
Antigen presenting cell, yes, sir. What we have the complexes on the cell surface, and we have the clusters, these cluster determinant complexes. The interaction between these will determine the functionality.
So does it mean that if a cell is infected and if the cell has been hijacked by the virus and the virus protein is present on the cell surface, which is recognized by MHC1 or MHC2, that means all cells which have a antigen on their surface will be APC?
No, which have MHA1 type, which is the self one, that will not be attacked. The one MHA2, which is any other antigen, that will be attacked.
So antigen presenting cells will be any cell which has multiple histocompatibility complex 2,
Yes.
which is antigenic in nature, will be. Yes.
Will be destroyed. That's why at the time of apoptosis, that apoptosis happens, that the self-presenting antigen is recognized and kept in memory, whereas the other one is not kept.
Okay. So antigen presenting cells can be, what can be the examples? Which are the cells which will be?
Sir, anything that's carrying a virus,
will become
a neoplastic cell, okay, or fungus.
Okay, so that's one. The
second allograft.
Yes, so APC will be there. Number 2 is when it comes to The first response in the body is a polymorph response. The second response is a lymphocyte response.
Lymphocyte
And today we are talking about NLR, NL ratio, that is neutrophil to lymphocytic ratio.
lymphocyte ratio.
So the first response is neutrophilic response. So how does neutrophil, from where it comes, it present where, and how it is attracted, and how it kills? What is the difference between neutrophilic killing and CD8 killing?
I may not be able to explain it that well because I'm basically not a biochemist.
I know.
But that is the general polyclonal response.
Should I take it like that? Should I take it like that? All cells which have granules are killers.
And sir, it also will be a polyclonic to a monoclonic response. There is an infection, the killer cells will, the granular cells will mount a response till eventually it will be the monoclonal cell that will kill it.
No, I'm only trying to understand this because I'm trying to form some basic formulas. So we have three granular cells, eosinophil, basophil, and neutrophil. All three contains granules. The role of a granule is to kill somebody because they contain proteolytic enzymes. So therefore, these cells are killers.
They will mount a general response, sir.
Yes, general, innate immunity response. And how will a lymphocyte kill?
That will kill by a monoclonal response. Very specific response to that entity.
So that is called as a monoclonal.
Monoclonal response. The first one was a polyclonal response. That is the general immunity.
So this lymphocyte will, when the lymphocyte or the NK cells come, CD3 or the CD8 cells come. Now CD8 cell will recognize the antigen presenting cell. Okay, it will get attached to that. And then how will it kill? Will it produce cytokine itself?
Cytokines, sir. It will produce cytokines.
So it will release cytokines.
Cytokines and kill by that, which will produce pores in the, which will destroy the plasma membrane.
The cytokines will, so it is an indirect killing, not a direct killing.
That's why it's called cellular immunity.
Cellular. And it will open the pores.
Pores. It will create pores in the plasma membrane and destroy it by that.
Now, once the cell is dead, apoptosis, necrosis, pyroptosis, whatever, a cell is dead. What happens to that? It is taken over by macrophages. No, that will be taken over by macrophages. Macrophages. They will do what?
Lysosomes will, it'll be eaten up kind of thing by macrophages.
So there will be some production of waste, because whenever you eat something, there will be some waste, which is a material which is not eaten. Where will it go?
It is auto-digested, sir.
100%.
100%.
So all the cells will show a auto-digestion, which is 100%.
100%.
Now, if this auto-digestion doesn't happen, why I'm now coming back is, this virus, we say this virus is non-replicative after 8 days, but the virus can still be detected for 3 months. And all of us are saying dead cells. This virus is dead. If this virus is dead, it has to be inside a epithelial cell or a alveolar cell or endothelial cell. If there is a dead cell lying in the body, that means that that cell is not being removed, auto-digested. What is that? Is there any? I mean, I'm going into lateral thinking, so don't.
No. There is no book that tells you this. We have to all think.
Therefore, I'm saying lateral thinking.
Maybe the overload is so much that they have not been able to clear the whole debris.
So basically, the dead cells can lie in the body. So there can be a defect. There can be a defect of reduced phagocytosis.
Reduced phagocytosis and a cell burst also.
Cell burst. So in that case, when there is a cell burst and reduced phagocytosis,
those fragments, although deactivated, will be lying around.
Fragments will end up into anything which is burst will end up into intracellular or extracellular
cellular debris.
Then they should go into lymphatics.
Possibly, maybe. Why not?
They may end up into lymphatics.
Into circulation also.
Into circulation. So circulation or lymphatics. I'm finding some unanswered questions I'm trying to find. So it is not, and because in this particular condition, lymph nodes are not enlarged.
Yes, they're not.
We are not finding lymph nodes enlargement in COVID-19 except for mesenteric lymph nodes. All other lymph nodes, cervical, mediastinal, because if there is a virus in the nose, in the mouth, there should be cervical lymphadenopathy. It is not occurring. So therefore, there has to be reduced phagocytosis because of something. Because if it is entering into the extracellular fluid, should enter the lymph nodes and should cause lymphadenopathy. So that means there is something which is preventing phagocytosis. Can this be the one of the answer? Again, lateral thinking.
Possibly.
Again, okay. So, number one. Number two is that apoptosis, normal phenomena of apoptosis is also linked with phagocytosis. That's what it is. Apoptosis.
It's more with lysosomal activity.
Okay, lysosomes are also present in polymorphs and everywhere.
Everywhere.
Okay, so I come back to again CD3, CD. Now, what is the difference between CD3 when it is a natural killer cells versus CD8?
I talked of the double negativity, single negativity and the double. They have
in terms of what they will kill. They have to, both of them will have to identify APC, antigen presenting cell.
Yes, sir.
Without antigen presenting cell, they will not. So is there a specific role? We don't know.
Not that I know. One can look it up, but I won't be able to say it now.
Then what about the suppressor cells, CD suppressor cells? वो कौन से होते हैं?
सर CD suppressor cell का function यही होता है कि positive और negative को balance में रखने के लिए. और मैंने
वो कौन से सेल कहलाते हैं?
मैं बताती हूँ आपको.
वो कौन से सेल कहलाते हैं?
मैं 1 मिनट ला रही हूँ वो स्लाइड वापस आपको. One second. सर इनका कोई स्पेसिफिक नाम तो नहीं दिया हुआ है किताब में.
मुझे भी नहीं. और दूसरा टी सेल रेगुलेटर्स, टीसीआर कौन से कहलाएंगे? सीडीआर, टी सेल रेगुलेटर्स, वो कौन से सेल होंगे?
सर उनका भी यही नाम है, टी सेल रेगुलेटर्स.
That's all.
That's all.
So we have T help suppressor, T helper,
natural killer,
and regulators.
Regulator cells
and T helper are further divided into CD4 and CD8. ठीक है. और इस कंडीशन में जब हम CD4 and CD8 कम हो रहे हैं, CD8 कम हो रहे हैं, इसका मतलब they are being used.
They are being used.
ठीक है ना? Because they are used, they are more used than produced. Therefore, CD4 count is reducing.
Right, sir.
And does it also mean that because indirectly CD4 and CD8 means lymphocytic count in TLC, total leukocytic count mein, absolute lymphocytic count mein. So will it also mean that if polymorphs are increasing or the lymphocytes are reducing, the virus is still active?
It would seem so.
It should seem so.
तो
इसका मतलब है कि हम लोग इस पे क्लिनिकली काम कर सकते हैं कि जब हम बोलते हैं वायरस लोड कम हो रहा है या वायरस लोड बढ़ रहा है,
तो हम इसको मार्कर बना सकते हैं देखने के लिए.
इसको मार्कर बना सकते हैं.
तो
we can say normalization of lymphocyte and polymorph response means virus is gone.
Yes, and their ratio, as far as it should come to normal, then the virus is gone. So
therefore we have one of the marker of a high viral load is early cellular response.
Cellular response.
Early
And
cellular
diminution of the lymphocytes,
diminution of the
the
lymphocytes.
lymphocyte count.
Okay, good. Because हम लोग तो इसको clinically ultimately anatomy को clinical use करने
Clinically convert करना है.
और कोई ऐसा तरीका है कि हम T lymphocytes को बढ़ा सकें आपकी मेरी उम्र में?
सर है ना एक ये आई विल शेयर दिस विद यू. मैंने अभी पढ़ा है इसको. Can I will share this. ये aging पे आया है सर. There are two drugs. Two drugs that have been worked out, which are supposed to increase the T lymphocytes.
Okay. So from my side, I sign off with the request to Madam Call कि एक तो अपनी slides दे दीजिएगा.
Sure, sir.
और साथ में वो मुझे reference दे दीजिएगा.
Sure, sir.
So thank you for a beautiful interaction. I will keep troubling you because I'm now becoming a student of anatomy.
Sir, you are most welcome. It is an eye opener for us to learn about COVID and all the depths of the molecular research. Thank you so much.
Thank you. Back to Dr. Datta.
The Indian Medical Association is very grateful to Professor J.M. Paul for her very informative talk. At least I have learned a lot today about anatomy and the thymus gland, which I was not aware earlier. At the same time, I am very thankful to our resource person and today's moderator, Dr. K.K. Agarwal, for sharing his views also along with Dr. J.M. Paul for this very informative talk on the thymus gland. And at the same time, I am thankful to Dr. Sanchita and the people who are behind the curtain for making this webinar a great success. Thank you very much.
Sir,
Thank you, everybody.
I want to say one thing.
Yes, madam.
That there's very lot that one doesn't know about thymus.
निकालेंगे मैडम. अब इसी के बारे में हम कर करके थाइमस को ही खरीदेंगे. एक चीज तो पूरे वर्ल्ड ने बता दिया, इंडिया इज द बेस्ट and America is not the best. So one thing, the way America has handled COVID, they have told us that they don't know how to handle a crisis. So they may be very good, but they don't know how to handle a crisis. We are going to take a lead and teach the whole world about the anatomy.
And that would happen only through discussion, sir.
Yes, that we will do. That is my job to do it. Thank you, everybody. We'll be back next week, next Saturday. Stay tuned. नमस्कार.
नमस्कार.
बंद कर दो लाइव को.